This morning, a woman heads to surgery to receive a new heart at one of the top heart transplant centers in the country. And Ken is inspired to take the mound less than 1 year after transplant. Interventional cardiac surgeons prepare to fix the tender heart of a 3-month-old boy. And 5-year-old Omari is heading to his first day of kindergarten, just like the rest of his classmates. This afternoon, farmers harvest vegetables from our hydroponic greenhouse, which yields more than 5,000 pounds of produce each year. And a high school senior named Luis is learning the nutritional value of baby kale. This evening, Lois is prepping for surgery to receive a double lung transplant. And Craig is accompanied by his guitar instead of an oxygen tank. All day, every day, Newark Beth Israel Medical Center and Children's Hospital of New Jersey are committed to providing world-class leading-edge medicine to every patient. A top teaching hospital offering state-of-the-art patient care and an anchor institution that thrives on empowering our neighbors and partnering with our communities to live healthier together. Newark Beth Israel Medical Center and Children's Hospital of New Jersey. Let's be healthy together.
Good afternoon, everyone, and thank you all for joining our Women's Health Panel discussion today. We're so happy to have everyone join us. Thank you for taking time out of your busy schedules to join, and we hope that we're able to give you some, good information, and we have a good discussion today. So I want to introduce our panel to start. We have with us Dr. Alice Cohen, the director of the Frederick B. Cohen, MD, Comprehensive Cancer and Blood Disorder Center. Hello, Dr. Cohen.
Good afternoon.
We have Dr. Nudrat Ayub, Internal Medicine and Obesity Specialist here at Newark Beth Israel.
Hello.
Hello. Dr. Alison Gambou. She's a third-year obstetrics and gynecology resident at Newark Beth Israel. And Dr. Christina Migliore, Director of Pulmonary Hypertension and Advanced Lung Disease Care at Newark Beth Israel. And she's also the director of our new COVID-19 recovery practice. Hello, Dr. Migliore.
Hi, thanks for having us.
Thank you. And Dr. Johanny Garcia is logging in as we speak. She is the Division Director of General Internal Medicine at Newark Beth Israel, and so she will be joining us shortly. So I know our panelists are very excited to answer all of your questions. I'm going to be monitoring the chat, so please feel free to send questions as we're talking. And before we begin, though, I want to start out with a general question for all of our panelists and sort of get a check-in and temperature check on where we are right now with women's health, and find out from you guys what is the best thing that we should do, that women should do to improve their health. And what would that be? I want to start with you, Dr. Cohen. What should women do to improve their health?
Well, thank you for having me. Just a little bit of background. I'm the director, as was said, of the Comprehensive Cancer and Blood Disorder Center, which means we treat women, and we do treat men, for cancer diagnoses that have been made by our primary care doctors or other specialists. We also deal with blood disorders, which can include inherited red blood cell disorders such as sickle cell disease. And we have a very large program where we address the needs, and in particular, work with women with sickle cell who might want to be pregnant. And we also run a blood thrombosis center where we deal with women who have bleeding problems as well as blood clotting problems. And again, in particular, we help manage in combination with our OBGYN team, many women who choose to get pregnant and might have complications that we can help prevent. That's a lot of things that we do. In terms of what I think I can advise women in terms of maintaining their health. In terms of cancers, there are some things we can control and some things we cannot control. What we cannot control is the genes that we were born with that might predispose some of us to cancer. If we have a family member, however, who has had cancer, it can be helpful to remember that story and start to talk to your primary care doctors about whether genetic testing might be of benefit to you as you are aging, and might have better screening programs that could help identify cancers early. In terms of environmental risk factors, many of you know that smoking is probably our greatest environmental factor. It impacts the development of many cancers, not just lung cancer and not just head and neck cancer, but certainly many GI cancers, even breast cancer, can be increased by smoking. So smoking, and I'm sure Dr. Migliore is going to talk about this, prevention is our #1 top priority. Eating a healthy, well-balanced diet, though we can't necessarily pick out carcinogens in our diet, we do know that maintaining weight, reduction obesity can reduce the development of some cancers, as well as improve outcomes when you have cancer. Those are just a few tips that we can start off with. I want to give everyone else some time. Screening, of course, is always essential, and our primary care doctors maybe will talk about some of the guidelines. The guidelines are constantly changing. And actually, I was watching TV yesterday, and there was a nice big ad reminding everyone that screening for colon cancer guidelines has now fallen in age, and it's recommended that everyone start screening at the age of 45 instead of 50.
Wow, I know there's always different recommendations, so it's good to have you guys on to sort of give us that, to give us the feedback and what we should be doing. Dr. Ayub, I actually want to go to you because Dr. Cohen talked about healthy eating and keeping a well-balanced diet and how important that is to try to prevent cancer, the development of cancer. Can you talk to us a little bit about your practice and your focus on obesity and weight and being overweight?
Sure. Again, thank you for having me. It's wonderful to be among all the physicians that are here. So I am an internist, internal medicine doctor, and with the subspecialty in metabolic medicine. And I deal or take care of patients with obesity or malnutrition. And I mean, we know that in America, almost 70% of our adult populations are either overweight or obese. The reason I got involved in the metabolic aspect of this of the medicine is that you know, we are trained. I'm trained to be a primary care doctor, which is the whole focus is on prevention. Obesity can be and is the source of so many diseases, including diabetes, high blood pressure, high cholesterol, arthritis, depression, and many cancers, as Dr. Cohen said. So by just taking care of this aspect of our life, we can prevent so many development of so many issues going forward. So absolutely, and in terms of females, everything that Dr. Cohen said we need to do. So we need to take some time for ourselves. Absolutely, the diet is important, sleep is important, taking care of ourselves, both mind and body, is important. You know, as females, we take care of everybody else around us, and we come last. So those are the things that I would advise, you know, my patients to start to focus on their both healthy diet, healthy body, and healthy mind.
Perfect, thank you. So you talked a lot about some of the things that Dr. Garcia deals with in her practice as well. Dr. Garcia, thank you so much for being able to join us today.
Yes, thanks so much, Linda. And it's really an honor to be part of this panel with the physicians. I know them personally, and I would definitely go to them or my family if I needed to, which I probably do, because I think as women, we often put ourselves maybe 8th or 10th on the list of priorities. So I'm guilty of that too. And my apologies for being a little late. I actually was just seeing a patient. And I think I just want to echo what Dr. Ayub said. You know, I'll tell you the story of this patient. I really believe stories are very powerful. But you know, the patient has been given a new diagnosis, and she explained to me that she plays the guitar, and since her diagnoses and her medical problems, she hasn't been able to play her guitar because she has some pain in her fingertips. So, you know, when I think of health, when I think of how to prioritize our lives, I do think of looking at people as a whole person, thinking about how the concept of wellness, Dr. Ayub mentioned, you know, body, spirit, and mind. And I want to add also family and personal growth. So all those things, all those parts of what makes us people, apart from our, if we do have medical problems, are important. And so I really encourage all those who are listening to make sure that you're thinking about those other parts of your life, including exercise, right? That will help you as a person and will help you take care of your chronic illnesses, and of course prevention, like Dr. Cohen said, in terms of cancer screening. So this is very important to all of us, and I hope that, you know, that session with my patient, I took a couple of minutes more just to make sure they that they know that we're going to help her play that guitar again.
That's great. That's great. Thank you. Thank you, Dr. Garcia. Dr. Gambou, I know we have a lot of questions. We have several questions for you. The area of obstetrics and gynecology, obviously that's something of very great importance to us as women. Can you talk to us a little bit about more about what you do here at North Beth Israel and what your advice is to women on how to improve their health in that area?
Sure. First of all, thank you for having me. I'm very excited and happy to be part of this panel today. So I am Dr. Alison Gambou. I'm a third-year OBGYN resident here in North Beth Israel. So my job is divided into obstetrics and gynecology. Although those two fields are intertwined, they are still kind of, you know, separate. In obstetrics, we take care of patients in the clinic. We kind of follow their pregnancy, during their prenatal care, all the way until it's time for them to deliver vaginally or perform C-sections. And we take care of high-risk patients as well as the regular low-risk patients. And then in the other field, in the gynecology field, we again take care of patients in the clinic, you know, seeing them during their annual visits or any problems with it that they might have, or just counseling them on reproductive, you know, health. And then the other side of it is also performing surgeries such as myomectomies, you know, performing abortions or performing hysterectomies. So I agree and I follow on what the other doctors on this panel have mentioned earlier. I think that some of the most important thing that we need to remember is just the basic things like staying healthy, having a healthy diet, monitoring our weight, making sure that we implement exercise, sleep hygiene. Those are things that are basics, but sometimes it is hard as women, especially when you're in charge of a whole family or depending on what socioeconomic issues arise, it's hard sometimes to prioritize these things. But if we are able to do that, then that's already half of the battle that's being made. The second part that I would say is that's very important is to always remember that the physicians are here, and it's important that the patients know that they can come to us and that they should actually come to their visits and be compliant with them, especially the annual visits. Because I think that a lot of people sometimes they think, oh, I should just go into my clinic appointment because I have my pap smear. But as a matter of fact, even if you don't need a pap smear, you should still come every single year and make sure that your health is in check. Same for pregnancy, compliance with your prenatal appointments, compliance with your ultrasounds. Those are things that will really help optimize every patient's health.
That's great. Thank you. That's good to know. It's like, yeah, you think, is it time for the pap smear or not? But it should be annually, right?
Exactly,
Yeah.
yes.
One thing that we don't, or we might not necessarily associate with women's health, Dr. Migliore, is your work with advanced lung disease. And I want you to talk to us a little bit more about your practice and some tips on how to improve our lung health.
Sure, thanks. Thanks for having me. And it's great to do this with all these wonderful women on this panel. Lights keep going on and off. So I am a pulmonary critical care physician. So I'm a lung doctor, plus I'm an ICU doctor. And so in our outpatient practice, we see a variety of patients with lung disease, encompassing everything from asthma, COPD, to fibrosis or scarring of the lung. We see pulmonary hypertension patients, which is more common in women. That's high blood pressure in your lungs, all the way down to lung transplant. We also have a post-COVID recovery clinic, which is, a big part now of what we've been doing and what we've been seeing. I think the first tidal wave of COVID came and hit us like a tidal wave, and now we're basically dealing with the repercussions of that. And lung disease is a big part of that. I think, good tips on lung health, as these female physicians have said, as women, we often put everybody else first before ourselves. And my mother has always told me, if you are not healthy, nothing works in your house. If the woman of the house is not healthy, nothing gets done. And we've all seen that personally as physicians. If you're sick, everything stops. So it is important for us to recognize ourselves and know our body, and know that the symptoms we feel are not just because we're women, whether it is fatigue and shortness of breath, which we see a lot of in our pulmonary clinics, is women with fatigue and shortness of breath, and not to just blow that off that we're just tired and we work too hard and we come up with a whole bunch of other excuses. As Dr. Cohen said, one of the things we can control is smoking. So smoking is a huge thing that we can prevent. And counseling on smoking, it's patients often come and they said, I smoke, and we tell them stop smoking, but we have to teach them how to stop smoking. And I think that's a huge part of what we need to do, and patients can learn a lot about ways in stop smoking. That has always been the #1 thing in lung health, right? But I think these days now is get your COVID vaccine. And now it has never been more easier to do it. I mean, months ago, we had to go through all these websites and register in this. And now here, you can basically walk in and get a COVID vaccine. You can go see your primary care doctor and they can forward you right over and you can get your COVID vaccine. So I think that now has become such a huge part of lung health, as well as if you have any other lung disease, just keep following up with either your pulmonologist or your primary care doctor. That's a huge way to keep, yourself healthy.
That's great. I know COVID is like the topic. We're going to talk now a little bit more about how COVID has impacted each one of your practices. But that actually leads us right into, we did get a few questions ahead of time. And I just want to encourage everyone to please send questions. The doctors, this is a perfect time. You have a captive audience here of physicians that are here wanting to answer your questions. So I just wanted to get to, we did have a few questions that were sent to us ahead. This one is for you, Dr. Gambou, about COVID. Has anyone come across a pregnant patient who was COVID positive, gave birth afterwards, and passed it on to their newborn? If so, how was recovery for the newborn baby? So it's a couple of questions in there, but maybe we can talk about COVID and if it's something that gets passed on to the child, if we've seen that.
So from here, the patients that we have had, especially during prime COVID time, most patients who were COVID positive and who delivered, the babies did not have COVID. And we were actually surprised. We're interested in figure out why that was and how the baby was protected. And then we've actually had, not in our hospital, but there has been in other hospitals cases in which case the baby turned out to be positive, but it was usually a few weeks after, not directly after birth. So the question is, do the infants catch the COVID once they're at home and they're surrounded by other people who are passing it on to them? Right. Or, so that's still the question. And I think that we're still trying to evaluate like what it means to have COVID in pregnancy and how will the babies be affected and how to prevent the transmission of that. But we haven't seen that happen here.
Okay.
And Christina could probably comment on why that is. It would make sense that the babies would not because of the way COVID is transmitted, correct, Christina?
Correct. Yeah. I mean, COVID we know is it's an airborne. It's an airborne disease. So as long as we're doing, the appropriate things, as, get vaccinated and, the mask wearing now has become better, but we know the transmission from it. And what really helped us get through this, number one was the vaccine, is wearing that mask, because it is an airborne disease.
Right, so the baby wouldn't have it when she was in utero, and then once born, you have to protect the baby from the airborne.
And all precautions are taken, during the delivery, after the delivery. Yeah.
We have a question actually in the chat right now. Thank you. We talk a lot about the things we need to do individually, but are there any support groups for women's health and wellness or for emotional support available at the Beth? Are any of you running support groups that you can talk about right now? I know that there are some with our Be Healthy program and our wellness initiatives over at the Reverend Ronald B. Christian Community Health and Wellness Center. So we can definitely share those after the chat with everyone. But if there are any others that you are running individually in your programs, feel free.
So, of course, we have a breast cancer support group that did continue despite COVID. Currently, it is as a online virtual like this support group run by one of our social workers who happens to be a woman as well. And we've had ongoing support programs that are for men and women through our sickle cell program. They have been virtual as well. We hope soon to be able to bring them back in person.
Nice.
We have an advanced lung disease support group for those patients who have severe, significant advanced lung disease and are considering an option of lung transplant. So our social worker here, she runs our support group for those patients. It's done virtually now, so hopefully, like Dr. Cohen said, we'll be able to all meet in person.
Right, hopefully very soon. We have a few questions here about screenings. And so I want to make sure we address that. Dr. Cohen, at what age should we get our first mammogram?
Dr. Garcia and I could have a debate about this because every organization has their own guideline, and it depends on some guidelines and then again some on personal family history. The American Cancer Society guideline has recommended that between the ages of 40 and 50, women consider having a mammogram every 1 to 2 years, and then yearly after the age of 50. The U.S. prevention guidelines that Dr. Garcia could comment really mainly start at the age of 50. So if you have a strong family history, breast cancer or ovarian cancer syndrome in the family, that screening could begin earlier. If you've had radiation therapy for another disease such as Hodgkin's disease, that screening could begin earlier. Most of the screening we're talking about is with mammograms, and the reason the delay to later ages is not because women necessarily don't get breast cancer at younger ages, but the tool of mammography is less clear in women who are still menstruating.
Oh, okay. That's good to know.
Yeah, I know Dr. Ayub also as a primary care physician probably wants to chime in. I think I agree with what Dr. Cohen said. And what I wanted to add is really, this is any kind of screening and any treatment is really a shared decision between you and your provider. So what I encourage my patients to do is, let's have a conversation about what is recommended. And of course, if you have predisposition, like Dr. Cohen said, a family history or other things that may put you at higher risk, we have to have a conversation because everybody is different. So what I encourage women is to have the conversation. Don't be shy. And then you can make a shared decision with your provider as to, what is the right plan for you personally. So I just wanted to make sure that you all know. do that.
Yes, I absolutely agree with Dr. Garcia and Dr. Cohen, but I just want to add on that, screening protocols that have been there, they are in general generally, but individually, what we also say, even at a younger age, to make sure that you are examining your breast whenever you are in a shower, and if you feel something, so that we all had no patients that were much younger than 40 or 50 that are cancer survivors or are going through breast cancer treatment at this point. So we just need to be aware of our bodies, and as we need to pay attention.
And on that note about being aware of our bodies and sort of doing, screening and preventative measures, we have a question about prenatal health. How in advance should a woman start taking prenatal vitamins?
So that's actually a very good question, and I think that's important to actually address that, because I feel like there's a misconception that sometimes you want to go see your OB/GYN once you're pregnant. And actually the best time to, start addressing, pregnancy is before you get pregnant. And we actually advise women to start prenatal vitamins 3 months in advance, 3 months before conception. And we have found that prenatal vitamins help in the development of the baby. They can help, decrease in rates of abnormalities, neural tube defects, cardiac defects, cleft palate, things like that. But also it can help decrease the amount of nausea and vomiting that a woman can experience in pregnancy too.
Oh, ding, ding, ding. That's a good, good tip. That's a very good reason to start taking them early. Thank you, Dr. Gambou. I have a couple more questions here related to weight loss. Intermittent fasting. What do we say about intermittent fasting as a
good one.
way to lose weight?
Really good one.
Intermittent fasting, there's so much out there in the social media on the line. I get this question all the time, and my patient comes in, and everybody's intermittent fasting is different hours and different times, and they're doing it in a different way. So it's considered as an intermittent fasting if you're fasting for 16 hours. And during that fasting, that does not mean that when you're fasting, you are keeping yourself hydrated. But then when you do start to eat, what happens and what choices you make, that's the most important thing. So just because you fast for 16 hours and then when you are eating and you're eating everything that you want to eat, that is not going to work. Intermittent fasting, definitely, there is a metabolic condition called insulin resistance, and which is one of the very common reason why a patient gains weight very quickly. And intermittent fasting absolutely helps you to reduce that effect of the insulin resistance as well. So I am a big fan of insulin resistance, intermittent fasting, but it needs to be done, I think, in conversation with your physicians, nothing extreme. And then when you do eat, you need to have a plan about that also, making healthy choices.
When you're drinking, when you're doing this, is a question I have. Is it only water that you can drink, or can you drink juice, or can you drink, what can you drink?
Well, so juices, I'm not a very big fan of. So it depends on what kind of juices are we talking about. So no, majority of the time when we are saying intermittent fasting, hydration is water.
Water.
So anything that was without the calories, basically.
Got it. Got it. And then we have another question about, and then we're going to go back to a little bit more about the vaccine, but I think we're almost ready to close it out. Belly fat, muffin top, dropping the gut, basically. How can we lose our that extra stomach weight without surgery? That's what this person's looking
That's another good one.
We all want that one, right?
So in female obesity, or this is the major thing that we have, our belly fat, or the truncal obesity, basically, as we call it. So again, there are some metabolic conditions that predispose you to have much more fat deposition around these areas. And yes, again, when I say diet, I don't mean not to eat, but I mean eating in a healthy way, low carb diet, decrease your organic and healthy diet is what we are looking for. But also exercise is important, but if you get evaluated for certain metabolic conditions, like insulin resistance, as we are talking about, that really can streamline what kind of a diet would work for you, because we all know that one type of diet does not work for everybody. We are individual for a reason, and those are the things that needs to be evaluated. So yes, the surgery, bariatric surgery works, but medical weight loss definitely works. It requires dedication, and the most important thing that we need to do is being consistent. So if you're looking for something quick, that just because I exercised for a few days or I ate good for a few days, things do not change. These needs to be on a consistent long-term basis that you have to make those choices. And it's not how fast we get there, but how long you stay in the game. And that gets you the results.
Right. We have
Linda,
one more question.
I just wanted to add something because in addition to what Dr. Ayub said, it's obesity and obesity-related conditions are so prevalent in our community. I know that you know that New York Beth Israel does a community health assessment to really, actually, I think we're going through that assessment right now for this year. And it's a wonderful opportunity for our staff and our providers to really understand what is on the minds of our community and our patients. And if I recall correctly, obesity was the biggest concern the last time that we did our community health assessment. So I do want to take pause and really tell women that you know, it is about healthy eating and making choices that lead us to a healthier life. So one of the things that I recommend to my patients are really learning how to read food labels. I don't know, like when you go to the supermarket and, you know, there's all those cereals, you know, and you're not sure even what to buy, right? Because you may buy cereal that the whole family is going to eat. And actually, you know, obesity in children is also very common. So learning how to read that food label, learning how much sugar is in a serving size. You know, we have fabulous nutritionists all around the country and here in New York, Beth Israel. And I know there are places online, people can get information about how to read food labels, but I think that's a really good place to start. And last thing, I must plug our greenhouse.
Yes.
To know that the farmers market is open and stop by. There are lots of, I think there are other food markets around Newark and maybe in the neighborhood that you live in, and take advantage of those leafy greens and to support farmers around the community. So I did want to make a plug for our market.
Thank you, Dr. Garcia. I know we're running a little short on time. If you'll indulge us for a moment, I think I just want to make sure that we address the how COVID-19 has impacted your practices before we wrap up, and it might address one question that we have here in the chat about bias in healthcare and how we're dealing with certain bias that we've seen that's come up. It's been brought to light for the entire country with the COVID-19 pandemic. Dr. Migliore, I wonder if we can start with you and what you're seeing in the COVID-19 recovery practice. I know you said that the long-term, that long haulers effect, it impacts women a lot more. So maybe you can tell us a little bit more about what you're seeing there.
Yeah, so it was interesting when we started seeing patients last summer actually come into the general pulmonary clinic with these vague complaints. And this is right about the time they started calling this long hauler syndrome. And we don't know much about COVID in general. We've learned a lot over the year, but there's so much more to learn. And so we developed this post-recovery clinic and we were seeing so many women. And I thought it was just us. I thought it was just Beth Israel. But studies have been out there that more than 20% of patients who've had COVID, and they didn't even get hospitalized. These are patients who tested positive for COVID, very mild disease, if any, are suffering long-term effects. And out of that 20%, some studies, 60 to 80% of those patients were women.
Wow.
So the fact that we were seeing women really resonated in all these studies that were done. And they often come in with the same symptoms. It's fatigue, shortness of breath, palpitations, and this brain fog.
Wow.
And we really can't explain it. And we go through a gamut of testing, and we work with cardiology, we work with neurology, with hematology, if we find, because COVID, even though it started off as just this lung disease, it's a multi-systemic. It affects your entire body from head to toe. So we're seeing a lot of this in this post-recovery clinic. And like I said before, COVID came and hit us like a tidal wave, and now we're left with the damage that was done. And I think it's going to be a huge impact on our healthcare system, especially in our community. I mean, our community was just overwhelmed with COVID, and you know, our hospital handled it, you know, amazingly well, and the community really rallied together. And I think that we're getting hit now, and women are getting hit the hardest because, again, they're the center of their household. And they are really strong, and they need to recognize these symptoms and know that they are not alone. And I think that's one of the biggest things we address, is telling patients that, especially the women, you are not alone in how you're feeling. It's not in your head. It's not some made up diagnosis, this long haulers post-COVID illness. There is an ICD-9 code for it. Like, there's an actual code now for post-COVID illnesses. It's recognized, and it's a real disease. And I think the more we talk about it, the more women specifically will not feel alone in how they're feeling. Like I said, you didn't have to get hospitalized. You didn't have to be in the ICU on a ventilator. You could have just had a very simple, mild case. And it usually occurs 6 to 8 weeks after they've gotten their initial diagnosis that they start really to feel lousy.
Wow. I mean, I know we talked a lot about, thank you, Dr. Migliore. We talk a lot about COVID. We talk a lot about long haulers. We still have a lot of people who are nervous or concerned about getting the vaccine. Dr. Gambou, I thought maybe you might want to address some of the concerns you're still seeing with the vaccine. We know, especially with pregnant women, I mean, we've already had some questions about it. How do you address the concerns? What do you say to women who are trying to get pregnant or are pregnant and are concerned about getting vaccinated?
I mean, the concern that the patients have is founded. Because COVID is still new, we're still trying to figure out what are the effects going to be in the long term, and we don't have the data yet to be for certain telling the patients what to expect. However, what we have seen is how COVID has affected the patients who had COVID and who are hospitalized in the hospital. And so as of right now, ACOG, which is the American College of Obstetricians and Gynecologists, they recommend that pregnant patients should have access to the vaccine, and it should not be prevented. They should not be prevented from receiving it based on the fact that they're pregnant. And so the way that I counsel the patients is that I divide it into groups. It should always be a discussion between the provider and the patient, and then we should always weigh the risks and benefits of receiving the vaccines versus not receiving the vaccines and taking the risk of catching COVID. And so, like I said, I divide them into groups: patients who are low risk and patients who have a higher risk. Patients who are low risk are patients who are healthy, who don't necessarily have pre-existing conditions, or patients who are not necessarily exposed to COVID, who are not working in the healthcare fields, or who are not working in those areas like, you know, the stores, the grocery shops.
Okay.
And, you know, for them, I would have a discussion and say, look, it's up to you, but, you know, these are what we have seen and how COVID affects pregnancy. And then when I turn to the higher risk patients, and these are going to be pregnant patients who work in the healthcare fields, who are constantly exposed with patients, or even the other, you know, healthcare workers who could also potentially carry COVID with them. And then also the patients who have pre-existing conditions such as asthma, COPD, diabetes, hypertension, and their risk of catching COVID and having a poor outcome is just higher. And so for them, I kind of suggest, you know, getting the COVID vaccine can prevent you from having a poorer outcome than, you know, receiving the vaccine itself. We have on the CDC, there's a VSafe registry, and there's approximately over 134 or 124,000 women who have received the vaccine. And what they do is they tell us what the side effects that they've had, and that way we can kind of like review the data. And what we have seen so far is that the most side effect that people report is going to be, the injection site, maybe erythema, like just pain there, fatigue, some chills, myalgias, maybe like low-grade fevers. And that's basically the same side effects that patients who are not pregnant will experience. And then when they review the outcomes of pregnancy itself in terms of preterm labor, miscarriage, in terms of breaking the water or stillbirth, the numbers of patients who have received the COVID vaccine versus the patients who are not being vaccinated are really similar. So there's no data that would suggest that getting the vaccine is going to affect the pregnancy or give a poor pregnancy outcome.
Right. Thank you. Thank you. It's very good to note that being pregnant and also having these other risk factors can also put you at high risk of being sick if you do get COVID, which would be a good reason to get vaccinated. Right?
Yeah.
Dr. Ayub, we got a lot of questions about weight loss and different diets. We have one about the keto diet as well. How has obesity and overweight in our community, how have you seen that grow during this pandemic?
So yes, so another term that came out from this is also like, everybody used to come in, my patients, and they say, oh, this is the COVID-10 or this is the COVID-20. And they are not referring to another virus, they're referring to 10-pound weight gain or a 20-pound weight gain. So, I mean, what we eat and how we live our life, it depends on so many factors that surround us. So, I mean, there was a survey from, I'm forgetting which site it was. I think it was the American Psychological Association that showed that 46% of the adult US population actually had the unwanted weight gain during this COVID. And what boggles my mind is that it wasn't the 10-pound or a 2 or 3, 4 pounds we are talking about. The average weight gain was 29 pounds. So that's huge. And understandably, the pandemic, the whole from March up till and people are still going through it. It has affected our livelihoods. It has affected us financially, psychologically, physically, inability to go out and just able to just walk few feet. So everything was just completely shut down. So yes, this is real, and in my practice, I definitely, the first few months were very difficult to handle because every single patient had quite a large weight gain. So COVID definitely has affected us in so many ways, not just people who got COVID and admitted, but also psychologically and in so many other ways.
And being overweight does put you at higher risk for complications?
Absolutely. So obesity was definitely one of those risk factors that were putting you at a higher risk. So people initially, when to get to the vaccine was not that easily available, obesity was one of those things that if you have that, you would be prioritized to get the vaccine as well.
Thank you. Dr. Cohen, you talked about the need to get screenings as the best preventative measure for against cancer. How has COVID impacted your practice and what you're seeing at the Cohen Cancer Center?
So a great impact, certainly concerns for patients who are receiving treatment for cancer who become immunosuppressed, a higher risk of poor outcomes should they get COVID, and a higher risk of contracting COVID, particularly early on because of the inability to understand how it was transmitted, the wearing of masks, and then the need to be in the healthcare system. Once again, being exposed. We had many patients then who did not seek care because of COVID, because of the fear of contracting it coming to the healthcare system. So patients who might be sick, and I'm sure heart attacks and strokes were also impacted, that they might not come to the emergency room, knowing that the emergency room was filled with many patients with COVID. And the concern that they would get it, and then really a big impact for our primary care doctors, not being able to have patients come in and be screened for cancer. And so the impact, again, we have late COVID, but we're seeing now a year plus later, patients presenting with more advanced cancer than we would have liked. So they did not go for screening colonoscopy, or even if they had symptoms, did not seek attention for that, did not go for mammograms. And we are seeing many more stage 4 cancers because of that. In terms of the vaccine, we strongly encourage, there's almost no group who should not receive the vaccine in our practice. We do have many questions. Patients are concerned that maybe they shouldn't get the vaccine, but there's absolutely no data that vaccinations worsen outcomes for any of our cancers or blood disorders. We have many patients who have heard of the idiopathic, rare, unusual blood clot that has happened with one of the vaccines, particularly the one in Europe, which we do not have here, but even the Johnson & Johnson, which was less than you might see, as our chair would constantly show us, less complications than we might from getting pregnant or taking oral contraceptives. But it is not worsened by any of the diseases that we have. The only contraindications would be a previous anaphylaxis to another vaccine, I think. So we do strongly encourage. We do have that conversation with all of our patients on a regular basis, trying to give them the best information they can, make them feel safe. Actually, anecdotally, many of our patients come in and say, "Did you get the vaccine?" And we're like, "Of course we did," and sometimes just telling your personal story that you got it. And I tell that every single family member and every single vaccine, because my whole family's had it and everyone's had a different vaccine. And but that we feel very strongly that it would protect us, and we don't know that it's totally going to be away forever, and it can impact all of your healthcare.
So thank you. So even if you're undergoing treatment right now, if you have cancer and you're undergoing treatment right now, you can get vaccinated?
Correct. Correct.
Dr. Gambou, we have a question about fertility. Can getting the vaccine affect fertility?
So that's a very good question, and I hear that question too in clinic a lot. But like I said, because the vaccine is still new, we're still trying to, figure out what are the long-term effects of the vaccine. So far, it has not affected fertility that we can say. We've had plenty of patients who received the vaccines and who have gotten pregnant. So.
Okay. Thank you. This has been so informative. We have a few more questions which we have to go to, and I think I'm going to open this up to both Dr. Ayub and Dr. Garcia, because the question is about sleep, diet, and exercise. Okay, I'll read it in order. How do we deal with severe insulin resistance outside of enough sleep, diet, and exercise? Are there other things to do to mitigate insulin resistance?
So insulin resistance is a condition where your body produces a lot more insulin than needed in response to the starch or the carbohydrate in our diet. And insulin, in a very, very layman term, I can tell you that it's a storage hormone. So it makes you hold on to your fat cells. And even if you are exercising or relatively eating a healthy diet, if you are insulin resistant, your body punishes you for just one piece of that bread that you had, or half a cracker that you had, that somebody else can have multiple of those and would be able to lose weight. So unfortunately, people with severe insulin resistance, the diet there's no magic medication that you can make go around, or a surgery that you have to follow the low carb and low starch diet. Absolutely, there are certain medications that we use very, very frequently that not only helps you with the weight loss, but absolutely address the insulin resistance. And metformin, which is one of the medication for one of the first line medication for type 2 diabetes, is one of those medications used for insulin resistance very commonly. But those medications, again, cannot work alone. It's absolutely the low carb diet that we have to follow through for insulin resistance. Intermittent fasting also helps you with insulin resistance. So these are the things that are, we see it all the time.
Okay. Thank you. I think we're going to go to our last question. This has been so informative, and I think we're going to have to do a special webinar just on intermittent fasting and the intermittent diet. Everyone is very interested in this. But the last question I'm going to go to is about addictive properties in food. First, I'll ask, are there addictive properties in food? And if so, how should we handle that beyond eating in moderation and reading labels?
So I am not sure whether we have addictive properties in certain food, but we have personalities that can react to certain foods in a different way. So we hear all the time, I have a sweet tooth. So there's nothing wrong with that, what they're eating. It's their personality that's what they yearn for. And some others, they want savory food. So it all depends. And again, it's not about what you want. It's about how you do it. It's not about how much we eat. It's about what we eat. So I mean, there's so many things. And again, this is much more. I cannot address the whole food thing in
Right.
just 5 seconds of an answer, because there's so much more. There's so much psychological stuff that goes behind it. So when I treat my patients, it's not just with the medication or what you have. It's we literally have to treat them in a complete way in terms of, if you're not, we all know that we have to eat right and exercise, and that's going to make us healthy and make us lose weight, but we are not able to do it the way that we need to do it. And that requires motivation, that requires therapy, that requires constant reminders. And that's why going to a physician who is specialized in that, going to a dietitian who can guide you through with that. So it's a whole aspect that you need. I mean, you really need a lot of support to get this thing done. It's one of the hardest things to lose weight, and there's a reason behind it, because there's so many things in our environment that is working against us.
Thank you. Thank you so much. I'll ask it because I know she's on and she's listening. How often would you perform intermittent diet per week?
Okay, so that is also very, very different for different individuals. Some people just do it throughout. Some people do it 3 times a week. Some people do it 5 days a week and not do it over the weekend. But it depends on what works for you. Some people can get away and get the response that they need with 3 times a week, or some people need to do a whole lot more.
All right. Thank you, and thank you, everyone. I think this has been very helpful for everyone who joined, and I hope it's definitely been helpful for me. I always learn something when I do these webinars, so thank you all. And we'll see you next time. We have a webinar coming up next week. It's our last week of Women's Wellness Wednesdays, and we're going to be speaking with Dr. Janice Johnson-Dias about women of color and how the COVID pandemic has impacted women of color in particular, and some of the disparities, healthcare disparities that women of color face. And then we're going to have a paint and sip, yay, that same evening next Wednesday. So very exciting. And we recommend that you join us for those and register. Go to rwjbh.org/NBIWHD, and you can register for our last Women's Wellness Wednesday events. And thank you all for joining us today.
Thank you. It's a pleasure.
Thank you.
Thank you.
Thank you. Bye-bye.
Bye.